Hello, everybody. Can you hear me? Good. We'll just wait for the last couple to filter in. Do you think? I wish my voice always sounded like this. Husky. There we go. Ready? All good? Hello, everyone. Hi. Welcome. Welcome to the Science and Technology Theatre. For those that don't know me, I'm Ross Upton. I'm the founder and CEO of Ultromics. For those that know me, the reason why my voice is a little bit husky is because I've done too much talking over the last few days, so it doesn't usually sound this deep, unfortunately. Today we have a session entitled AI, Revolutionizing the Diagnosis of Heart Disease in Echo. We're very lucky to be joined by two esteemed cardiologists giving talks and showcasing our joint research together. Firstly, I'd like to welcome Dr. Patricia Pellicer, who's going to be presenting some work that we did together on how we can use AI to detect heart failure with preserved ejection fraction. So I'd like to welcome Patty.
Thank you, Ross. Hello, everyone. This is truly an exciting subject. I think AI is going to revolutionize the diagnosis of heart disease with echocardiography. I will be speaking about the work that I have done in collaboration with the Ultromics team on detection of heart failure with preserved ejection fraction. The objectives of my presentation are regarding the understanding of the challenges in assessment of diastolic function by Doppler echocardiography. And I think you will also appreciate the future role of AI in echo for increasing quantitation, reducing variability, improving efficiency, and accurately detecting disease. I was inspired to do this work by the collaboration I had with our colleagues applying AI to the 12-lead electrocardiogram. And it is really impressive what they have accomplished. Using paired ECG and echo data in more than 40,000 patients, they trained a convolutional neural network to detect an ejection fraction less than 35%, and then tested this in an independent sample, another 40,000 patients, and achieved an AUC of 0.93 and an accuracy of 86%. So this is without any other information, just detecting a low ejection fraction from a 12-lead ECG. They have also applied this technology to detect hypertrophic cardiomyopathy, AUC 0.96, to identify atrial fibrillation in patients who were in sinus rhythm, but at risk of developing that, AUC 0.97, to estimate the age of a patient, to predict the sex, and to detect cardiac amyloidosis, AUC 0.9. So really impressive. So I thought if you could do this with a 12-lead ECG, just think of what you could do if you applied AI to an echocardiogram. Of course, echocardiography is much more complicated. We have large studies. Our average study is about 120 3-beat clips and about 350 to 500 megabytes. Here you can see a 3D short-axis view of the tricuspid valve with tricuspid regurgitation that was present in this malcoapting valve. But there's so much complexity to applying this to echo because of the large amount of data, the different views, the skill of the sonographer acquiring the images, different ultrasound vendors, so many challenges. Then ASC in 2019 put out this RFA, the E21 research grant, and I wanted to use Mayo Clinic database of 2.7 million echocardiograms to do some sort of AI project. Our database seemed well suited to this because we do very comprehensive echocardiograms. Our reports are detailed. We have the cardiologist review the study before the patient is dismissed from the laboratory. We also have a variety of clinical characteristics in our database. We're a multi-vendor laboratory. We have a nice linkage to our electronic medical record. And for patients from Olmsted County, we have linkage to their events and outcomes as we are the major healthcare provider for the county. Moreover, this has really been the passion of my career, to link echo features to clinical outcomes. So of course, I applied for this grant. I decided to pick a problem that was really big, really important clinically. And so I selected heart failure as the challenge that I wanted to tackle. Obviously, this is a huge problem affecting 6.5 million US adults, and this is expected to increase by 46% by 2030. The morbidity and mortality related to the diagnosis of heart failure is very large. It's an expensive diagnosis. And in particular, heart failure with preserved ejection fraction is increasing in prevalence. It is especially challenging to detect, and it's becoming the most predominant form of heart failure worldwide. Now, truly the difficulty in performing and interpreting Doppler echocardiography leads to challenges in diagnosis and worse outcome for patients with heart failure with preserved ejection fraction. Now, you're all familiar with these many parameters that we measure in evaluating diastolic function with Doppler echocardiography. We use tissue Doppler of the mitral annulus, the mitral inflow. We measure time intervals, isovolumic relaxation time shown here, the tricuspid regurgitation velocity, and left atrial volume index. Then we apply these elegant ASE guidelines for evaluating diastolic function. And this is a 38-page guideline document. It's very detailed, nicely written, very thoughtfully produced. However, a number of groups are excluded from the algorithms in these guidelines. Patients with atrial fibrillation are a challenge. Patients with mitral valve disease and patients with prior cardiac surgery, particularly valve surgery. Moreover, the Doppler assessment requires accurate alignment of the Doppler beam with the direction of flow, and the sample volume needs to be properly positioned. The gain settings need to be correct. All of this makes it challenging to accurately assess diastolic function, and there are differences of opinion in some patients. My hypothesis was that perhaps we could detect heart failure with preserved ejection fraction from an apical 4-chamber view. Now, of course, this view really contains a lot of information. We can see ventricular function atrial size, motion of the mitral and tricuspid annulus, as well as lots of other little features, calcification of the annulus, motion of the atrial septum, and maybe all of those things would be important to the computer in detecting heart failure with preserved ejection fraction. So the aims of our study were to develop a deep learning-based anatomic segmentation model for echocardiograms to assess systolic and diastolic information throughout the cardiac cycle, and to develop a deep learning model to automatically interpret echocardiograms for detecting and prognosticating heart failure at the point of care. Happily, I received the generous award from the American Society of Echocardiography Foundation, and I was thrilled to have the opportunity to do this study. However, what I needed was an AI engineer to collaborate with. Rochester, Minnesota has not been a hotbed of activity for AI engineers. Happily, I had been in communication with the team at Ultromics as we had been talking about EchoGo and EchoGo Pro, their method for evaluating stress echo to detect coronary artery disease. And so a collaboration was born between Mayo Clinic and the Ultromics team from Oxford. This illustrates the work that the Oxford team at Ultromics had already accomplished. They had already developed a classifier that recognized the different cardiac views and that would select the best clip for assessment. They had already developed auto-contouring and recognized the stages of the cardiac cycle. They could extract the end systolic and end diastolic frames. Moreover, they had developed many feature calculations already, exploring several hundred different ways of looking at the left ventricle and measuring wall thickening, tardokinesis, and many other features. And they had developed a report and standardization for left ventricular volumes, ejection fraction, and strain. So together we began the task to develop a classifier to detect heart failure with preserved ejection fraction. And from our database of patients with preserved ejection fraction, that is more than 50%, we identified 3,785 patients without heart failure, that is no preceding history of heart failure and no heart failure within a year after their echo, who had normal or just mildly abnormal, perhaps age-related diastolic function, and another nearly 3,000 patients with heart failure and preserved ejection fraction and clearly abnormal diastolic function. We withheld 15% for validation. And we developed this classifier by feeding in this apical four-chamber view. These are the results. For the training set, the AUROC was 0.97, and for the validation, 0.95. We were pretty excited about this. And we went on to test it in a separate population of nearly 350 controls and 350 patients with heart failure and preserved ejection fraction. In this test population, we made sure that the patients and controls were matched for age, sex, and their year of echo. These studies were performed by different sonographers and interpreted by different physicians. The sensitivity and specificity were about 85%. We are really excited about these results. This shows a heat map or GradCam that illustrates what the model is looking at. And as you might expect, it's looking at motion of the mitral and tricuspid annulus and also the atria and other features. Different things being explored at different parts of the cardiac cycle. So back to our examples. The first patient was a 53-year-old woman who was referred for an echocardiogram for evaluation of a murmur. And the model came up with a heart failure preserved ejection fraction score of 0.001. So this would be predicted to have a very low likelihood of heart failure. The model has high confidence that this person does not have heart failure. On the other hand, for the patient on the right-hand side, this was a woman with dyspnea and acute on chronic heart failure with preserved ejection fraction. The score was very high in this patient, indicating high confidence that this was heart failure with preserved ejection fraction. I am truly grateful to the American Society of Echocardiography for providing me this grant, and it has been absolutely a pleasure to work with the talented team at Ultromics. They're pictured here. The team has shared my passion for making something that is going to have the potential to improve care for patients worldwide, to improve standardization and improve ease and facility, accuracy and reproducibility for detecting heart failure with preserved ejection fraction. I'm also grateful to my colleagues at Mayo Clinic, my research collaborators, who have been extremely valuable in helping me with this large project. Our next steps are to continue to refine the models, to test it in diverse populations, to relate the results to clinical heart failure risk scores, and also to long-term mortality in various populations. We need to validate this technique, this model, using point-of-care devices. It is my hope that AI and echocardiography will allow us to increase the quantitation of echocardiography, and I think in this era of multimodality imaging, this is absolutely crucial. Echocardiography must be quantitative. AI will allow us to reduce variability and will facilitate detection of disease. It will also allow us to relate echocardiographic results to clinical outcome and to guide therapy. This is a recent figure published in JACC that shows the application of AI in cardiovascular medicine. It will allow us to increase accuracy of diagnosis and selection of therapy. This will impact clinical practice, not only for our individual patients, but for populations. This will facilitate more optimized allocation of resources. We can apply this to remote and continuous monitoring. We can extend the efficacy and efficiency of our physicians. We'll be able to integrate this with multi-omic data from the EMR. This will allow precision disease stratification and will even be applied to research and development and novel therapies that will be discovered and developed to improve patient care. I thank you for your attention, and to Ultromics.
Thank you, Patty. Thanks for that talk. I think, as you mentioned, the prevalence of HFpEF is only increasing, and it's being recognized as one of the biggest unmet needs in healthcare today. And the fact that we've collaborated together and We've been able to develop a classifier just off a 4-chamber to detect heart failure with preserved ejection fraction. Has quite big implications for how we detect and manage and monitor heart failure patients going forward. So we're super excited about that. Moving on to Dr. Federico Ash. So Dr. Ash is going to present some research based on how zero variability is so important to patient outcomes in part of a collaboration we did with the WAYS 2 study. So I'd like to welcome Dr. Ash to give his talk. Thank you.
Thank you, Ross. It's a pleasure to be here this afternoon. Let me see. Yeah, here we go. So I'm going to present some data that we collected through the WAYS COVID study. But before I start there, I want to have a little bit of a perspective or build on what Patty Pellica already mentioned about the role of AI, or the potential role of AI would be not just in cardiovascular medicine, but particularly in echocardiography. When we look at the multiple steps that it takes for us from the moment that we get a patient on the table to be scanned until the information is collected and is built into our decision making that goes way beyond just the images, but actually on the collective interaction, if you will, of the imaging data with the clinical data. There's really multiple steps where machine learning and AI can play a significant role. It really involves not just the images, which is what we do the best, but actually the things that we are not that much used to, which is what are the clinical implications? How is that this echo data we are collecting and we're building actually interacts with the information we collected on our history taking, on the physical examination, on our other biomarkers or other pieces of the health data of a specific patient. So that data integration between the echo and all the data that we collect on the electronic medical records actually provides a very unique, super powerful tool that can take us way beyond what we are used to do on the day-to-day from an echo standpoint. So really, whether machine learning helps us at the steps of acquiring images, at the steps of labeling each of the images as of which view it is, after deciding which of the view is presented to the machine, to decide which measurements could be made out of that image, what kind of data can be collected from that image, giving us the opportunity of reviewing those measurements, if you will, or those parameters that are being collected, and how that will be built into a report and the report built into the medical record of a patient, and how that can actually have an impact on clinical decision making and on understanding the prognosis of a patient. Prognosis is the point that I want to make a very strong point here, because that's what we were aiming for when we built the WAYS COVID study. And I'm going to get back there. So what can AI bring to echo? Well, it will probably improve accuracy. It will increase the reproducibility of the analysis that we do, and it will make us faster, will make us more efficient. And probably there's much more than this, but if you ask me today, what are the 3 pillars that will support the utility of machine learning techniques in echocardiography, one way or the other are going to build in one of those 3 pillars. So the real question here is how crucial is to have minimal variability or the highest reproducibility possible. Can it help us improve prognostication, understanding what the outcomes of that patient are going to be? With that in mind is that we actually built a project that is called the WAYS COVID study. You may have heard about WAYS study to begin with. We started this program by trying to understand what is normal in a heart and what is outside of the normal ranges or the normative values. That was our initial project. When the COVID pandemic hit us, we had a very particular question. We wanted to learn about the phenotype of the heart on a patient that is infected with COVID. We wanted to learn how COVID was affecting the left ventricle, the right ventricle, and so forth. So as independent investigators, both Dr. Lang and myself build that community or use that community we built with the WAY study to try to put together these investigators from around the world and answer those questions on a really fast-paced manner, which is really what was needed at the time of the pandemic. We wanted to learn about it quickly and well. So that's really what triggered the WAY's COVID study. The WAY's COVID study comes from a few assumptions. Transthoracic echo has emerged as the leading cardiac imaging modality for patients that were admitted with COVID-19 infection. Just think 2 years ago, not the COVID of today, but the COVID of early 2020. That's really when this started. As a reader-dependent technology, fully automated AI-based analysis we thought should result in lower variability of results than those that were obtained by human reads. So we had an interest on having a more reproducible, accurate way of looking at those left and right ventricles. With increased interpretation consistency, it is foreseeable that the use of automated measurements could improve the capacity to predict outcomes. Again, predict outcomes. That's a key point in this clinical trial. And it's actually the reason why we partnered with Ultromics in this specific project, because we knew about their previous experiences on predicting outcomes in coronary disease. So there were multiple ways that we could actually partner in a situation like this. So the aim of the study was to explore the association of echo variables with in-hospital mortality, which is what we call the phase 1 of the WAY's COVID study. And the phase 2 was to describe the performance of machine learning-derived algorithms for prediction of death in patients that were admitted for acute COVID-19 infection and its incremental value to that of expert echocardiographer analysis. So there were 2 questions in one study. The design of the study was the following. We've had an initial phase that was a retrospective enrollment, so patients that were admitted to the hospital with COVID-19 that had to be proved with PCR or antigen testing and had an echo at the time of admission, those patients were going to be considered to be enrolled in the study. The second phase was actually a prospective follow-up. So once the patient was already in the hospital and had an echo, then we would follow those patients to really look at the one outcome that we cared about in this case, which was all-cause mortality. And we followed these patients for a minimum of 3 months and a maximum of 9 months. We very quickly launched this study, and we used 13 centers around the world from 9 different countries. In a couple of months, well, a little bit more than that, probably 4 months, we had 870 patients enrolled in all those countries that you see there in the list and in the world map. So you see that it actually reflects not just the practice of one specific area, but actually from multiple continents. When it comes to the echo, as I mentioned before, patients that were admitted with COVID-19 and were already tested positive for COVID-19 and had an echocardiogram that was done by the standards of each of the centers. So we did not have an acquisition protocol for them to follow because we understood that at the time of the pandemic, we were all scared about getting the infection, our sonographers getting infected. Each center had either a very limited echo that they were doing or a more comprehensive one, depending on the clinical situation. We respected that. So each of the 13 centers actually had their own protocols for acquiring the echoes. Now, those echoes were uploaded on the cloud to be transferred to the core laboratories. The core laboratories were at MedStar and at University of Chicago. On that process of being transferred through the web is that they were having their first pass on an analysis of the echoes. So these AI-based algorithms that were based on the cloud would analyze the echoes to give us a left ventricular ejection fraction and a left ventricular longitudinal strain, and the volume, and left ventricular volumes as well. Then those echoes, as I mentioned, were transferred in the core lab, so they were also analyzed by the same parameters, left ventricular ejection fraction and longitudinal strain. In addition to that, we performed some extra analysis that the software could not provide at that time, which was right ventricular strain. To be able to validate that the measurements that were provided by the cloud software were actually accurate, we had each echo not only analyzed by the AI software, but also by 2 independent echo experts. And then we had 3 readings for each echocardiogram. 2 that were experts, 1 that was the AI. The average of the 3 was the number that was used for the prediction model on this first phase of the study. So we had 3 measurements for ejection fraction, 3 measurements for end diastolic volume, for end systolic volume, and for the left ventricular longitudinal strain. These are the characteristics of the population that we enrolled, these 870 patients. As you can see, it's very well describing the initial population that was admitted with COVID. 40-something patients were in the ICU, 46% were in the ICU, 27% were on mechanical ventilation, 20% had some kind of hemodynamic support, whether it was drugs or devices, and you can see there all the previous conditions that patients had. So very, very sick patients to begin with. Indeed, when we looked at in-hospital mortality, we saw that the overall mortality was almost 22%, and it was a little bit different according to the regions of the world. Patients admitted in Asia had the lowest mortality. Patients in the US and Latin America had the highest mortality. So when we looked at the left ventricular longitudinal strain and the EF to predict in-hospital death, and again, remember, this is an average of 3 measurements. 2 of them were manual, 1 was the AI-based one. We learned that left ventricular longitudinal strain was actually a predictor of in-hospital mortality, but the ejection fraction was not. So the conclusion of this initial phase was that when measurements were average, longitudinal strain and right ventricular free wall strain, again, that was done with a different software, in addition to age, LDH levels, and previous lung disease were independently associated with in-hospital mortality, while ejection fraction was not. Now, interestingly, when we looked at that initial data and we separated now the readings that were done manually by experts and the readings done by the AI systems, we saw some difference, which was not dramatic, but was actually very important. When you look there in the green bars, the AI measurements were actually able to predict much better than the manual measurements which were the patients that were going to die in the hospital. Again, it's the same echo, but analyzed in 2 different ways, by experts or by the machine. So the second phase hypothesis was that EF and longitudinal strain obtained using AI-derived algorithms will have less inter-reader variability and will result in a better predictor of mortality than the expert readers. For this second phase, we made it a little bit more complicated when it comes to analysis. So we added a second round of reading by the AI system, and we added a third round of reading by an expert. So now we have 5 reads on each echocardiogram, okay? 3 of them are manual, 2 of them are AI-based. Not only now we have more data, we actually have the capacity to do an inter-reader variability. We can compare AI versus AI, and we can compare expert versus expert. That's really the goal here. So we had 476 transthoracic echoes in which both the AI and manual measurements were able to be obtained. We did a follow-up that was 230 days plus minus 115, and during that follow-up, the mortality was a little bit higher, of course, than the in-hospital. It was 27.4%. When we looked at the variability and we compared AI read 1 versus read 2, and manual read 1 versus 2 or 2 versus 3 or so, what we saw was, to not surprise, that the variability was very, very, very small on the AI side. Just for your reference, what you see there in green, those are the AI ones. When the R value is close to 1, that means the variability is minimal. When it's closer to 0, that means that the variability is tremendously high. So the closer to 1, the better. And the same thing for the intra-class correlation. What you see there is for AI, the numbers are very, very tight, close to 1. For the manual ones are more close to 0.6. And that is a very significant change in variability. And that held true both for the ejection fraction and the longitudinal strain. What you see there, those 3 sections there for all frames, same frame and different, what that means is if we take all the echoes, the number is the first row that you see there. When we take those echoes in which the same frame of the echocardiogram was used, that's the row in the middle. And when the machine happened to detect 2 different frames and make the measurements from 2 different frames, or the manual operator did the same, then that would build on the third row that you have there. So what were the factors responsible for within patient variability? Well, in AI, the variability was very, very small, and it was almost exclusively due to different frame selection. So if the machine detected frame, let's say 30, and the second round it selected frame 31, that's what gave the variability, okay? Very different when it came to the manual reading. The problem there was mostly who was the one reading the echoes. So there was more a variability that was dependent on the operator. This is another way of showing. This is specifically to the AI inter-reader variability, and to show that it was really according to the frame selection. What you see there on the left side of the screen is the variability when different frames were used. What you see on the right side is the variability when the same frame was used, which is almost negligent, almost 0. When it comes to prediction of mortality on multivariable forward-step logistical regression, you see they are marked with arrows. The AI algorithms actually performed in a way that was significantly correlated or significantly predicted the mortality on the follow-up. When we used the manual numbers, that number was not significant. So really what this means is that although numerically the change was not that different, it actually made a very significant change in the capacity to predict. So AI could predict outcomes, manual readings could not. There were some limitations of this study. Patients were enrolled in a retrospective manner. Not all echoes could be quantified. There were a good number. It was in the COVID era. We were all rushing through the patients. The image quality was not necessarily optimal, definitely was not optimal. And the findings may only be applicable to patients with COVID-19. I don't think we can extrapolate this to other populations, but it's on us to be able to prove that it actually works in other populations. In conclusion, for this second phase, automated quantification of EF and longitudinal strain using AI minimized the variability. AI-based LV analysis, but not manual, were significant predictors of in-hospital and follow-up mortality, and the AI analysis of echoes could increase statistical power to predict outcomes in clinical trials, possibly requiring smaller sample sizes because of that decreased variability on the analysis. So I want to acknowledge all the investigators from around the world that participated in the WAIS COVID study. A lot of people, as you can see, but it was really the only way that we could pull such a large study in such a short period of time. So I'm going to leave it there, and Ross, bring you back to the microphone. Thank you.
Thanks, Federico. That was a hugely impactful study, and really highlights the importance of how zero variability or reducing variability can have such a meaningful impact on patient outcomes. Now, I think we're more or less on time at time, so we don't have time for too many questions, but I'll probably just say some closing remarks. And if anyone has any questions, we're going to be around at our booth, and we're going to be around all day tomorrow. Hopefully I'll have my voice back by then, although I quite like the way it sounds, actually. Sounds better than my normal voice. And we're also going to be around Tuesday. But I'd like to close by saying, I think firstly, what Federico highlighted was full automation. We've been talking about automation in Echo for a long time now. And I think where we had got to was really, if we're being honest with ourselves, we've got to semi-automated. And when you've got semi-automation, it means that, the more contours are adjusted or views are selected, I'm being shut down, then the more variability, then that's more error that's being introduced into the measurement, which is worse for patient outcomes. So if you can take out variability and get it to zero variability, then you can improve patient outcomes, which I think is hugely important. And Federico's showing that nicely. And then coming to Paddy's talk, being able to improve HFpEF, we actually got a breakthrough from the FDA, a breakthrough device designation for that HFpEF classifier just a few weeks ago. So that will hopefully be on our platform at some point at some point this year. So we now have the ability to do fully automated EF, strain, HFpEF, all on one platform. I think the implications for being able to analyze, measure, monitor heart failure patients in the Echo lab, driving efficiencies, driving patient outcomes, but also taking that out into the community and getting to patients before perhaps they become symptomatic, and getting to the point where we're only feeding Echo labs patients that really need to go instead of seeing such large proportions of kind of normal patients. I think that's when we're starting to really change the way that we do medicine, and that's what really excites me as a founder and CEO of Ultromics. So we're going to continue to do our patient outcomes focused technology. That's the only way we're building it. It's always going to be correlated to patient outcomes, and yeah, we're excited for what's next. So thank you all for listening, and yeah, come find us afterwards. Cheers.